Okay, well, welcome to the Atlantic Implant Institute. I want to do a little tutorial on placing implants here. We're using S.I.N 360 implants here of the EpiCut dummy implants. These are the aluminum implants that we use for typodonts. So we're going to be doing this here on the first time on this model. So it's all going to be a new field to me. I've been using S.I.N implants. I did a few cases several, maybe 3 years ago. All cases are doing really, really great for S.I.N 360. We've recently, a few months ago, switched over our practice into S.I.N 360 implants. And so I want to give you a little demonstration on these implants here for our courses and for your own knowledge. So this little model that we're using right here was provided by S.I.N. It is feels like an injection molding model. We're going to get a little feel on how it feels. It's typical. It's kind of funny. The maxilla is very small in relation to the mandible, but this is oftentimes the way that it goes in regular treatment as well, although this is a pretty severe example. But we're going to be placing 4 in the mandible and 4 in the maxilla for a standard all-on-4 TM, if you will, arrangement here. This is for your basic fixed immediate load FP3 hybrids, okay? So I've got 3 cameras going here now. We've got 1 over top of the model. We've got 1 in front of the model here, and we've talking to you on for the face model. So what we're gonna do first, what I like to do, is I've got a pilot drill on here. I'm going to get a feel for the bone. Now, typically, the arrangement for these is going to be 23 and 26 are typically straight formats, and then the angled implants are usually 30. We're going to back up just for a second here. One thing that I often recommend for beginners and advanced people alike is keep a sterile pencil on your tray. I like to sometimes especially for assistants, I like to outline where the mental foramen is, where that nerve is going to be, okay? We're going to know where that was coursing throughout the mandible, all right, through our CT scans, okay? We can sometimes use this after our alveoloplasty, and by the way, the alveoloplasty looks like it was already done. So assuming a good incision line and an alveoloplasty, I'm going to back up and I'm going to show you. I like my incision lines to come right in front of that retromolar pad and then mid-crestal, and then a nice oblique releasing incision in front of the retromolar pad again, just like you were pulling out an impacted third molar. You can see that right here. All right, so you've got the flap out of the way, you've done your alveoloplasty, and then you're going to place your implants. Typically, these are placed in the 23 and 26 positions, here and here, okay? You can see that there, all right? And then typically, it depends on the position of the mental foramen, but if the nerve is very low and posterior, we get more of an AP spread. If it's very high or anterior, we get less of an AP spread. But typically speaking, we're going above that mental foramen, just above it, and then we're angling to the front, in front of that. We're usually angling about 30 degrees. All right, so I'm going to show this in the overhead camera. There's about where we want to enter for the osteotomy. And then we're going to be going down at 30 degrees to avoid the mental foramen and any anterior loop of the inferior alveolar nerve that might be present. And here we're going to do the same thing on the left side. This is the number 28 position, and we're going to be shooting 30 degrees. I can even go a little more posterior than that. We're going to be shooting 30 degrees in front of the mental foramen and the anterior loop. Typically, I'll tell you anterior loops, the typical rule in the analog world used to be 5 millimeters anterior. That was in the 2-dimensional radiograph days. Nowadays, we can use our CBCT analysis to really measure how far that anterior loop goes. And it's very seldom that I see an anterior loop that goes 3 to 5 millimeters. Usually they're more coming out directly 90 degrees to the mental foramen, or maybe just 1 or 2. So use your CBCT to help you guide you, or even better, maybe you want to use stackable guides or some kind of robotic or XNAP surgery as well. Or if you're really experienced, you won't find any trouble at all staying away from that inferior alveolar nerve and the anterior loop. So we've used our pencil, get an idea roughly where we want to place these osteotomies. One thing I'll often do is just create a little dimple. Usually I'll do this with a round burr, but for the sake of time and because I don't have a round burr sitting right in front of me right now, but a lot of times I'll just kind of place a little dimple just to see where I'm at in relation to all my anatomical landmarks, and decide, is that a good place for me to start? So first you want to start with do no harm, all right? Because we just did a little divot in the bone right there. And then it gives us a chance to put our handpiece down, go back and reassess all of our angles and where we want to be and see if that's perfect. So if I decide that those are my 4 entry points, if I decide that that's good in those 4 areas, I'm going to go through and I'm going to drill 2 at a time in my mandible. Now, again, typically these are straight up and down, usually 0-degree MUAs, 0-degree emergence for the implant. Of course, your occlusion and your skeletal relationships will dictate, but usually in 23 and 26, we're usually going with a 0-degree abutment. And I'm going to do this for the benefit of the camera and not for my eye. So forgive any small quirks in my angles, but I'm not really above the chair looking down for the purpose of surgery and the benefit of the patient, but more so for the benefit of this exercise. So I typically will drill in about 6 or so millimeters, and then I will reassess and see where I'm at. So I'll put on my 2-0 osteotomy drill so that I can put a guide pin in there. And we're going to go about 6 or so millimeters in on 23 and 26. And let's see if we like our arrangement here, if we like our angles. Okay, so this is a completely freehand surgery done from an odd perspective on a typodont. And we can see that we've got a pretty good relationship here. Let me get in front of the camera. All right, got a pretty good parallel there. All right, maybe they're leaning a little bit to the right. All right, looking straight up and down. Looks like we've got a little bit of parallelism, fairly good. This is good enough. It would be a little bit better probably if I was using the correct orientation of my eye to the patient. But let's go ahead and carry this all the way to depth. Now, my dummy implants are currently 13 millimeters, and I usually carry my osteotomy just a little deeper. If I'm planning a 13, I'll usually drill the 15. Just makes it a little easier to seat it. And then of course, if your implant goes too deep, when you get your primary stability, you can easily just take off a little bit more bone or use a longer multi-unit abutment. So there's our 23 and 26. Not too bad. Leaning maybe 8 or so degrees to the right, but totally acceptable for an all-on-4 with a multi-unit abutment. So that's down to depth. Now I'm going to use that 2-0 osteotomy drill, and I'm going to get my 30-degree. All right, so I'm going to come in above the mental frame, and I'm going to find that divot point that I made. All right, again, I've already looked at the CBCT. I know that there's not much anterior loop here, so I'm going to turn this about 30 degrees. And I'm just going to go in about 6 or so millimeters. Now, I have a paralleling pin. I like paralleling pins right here. I go in about 6 millimeters. I go ahead and drop my parallel pin in. And we like to see, does this look like it's going to be relatively straight? Let me turn these around. Got my camera going the other way. All right, so now, does it look like it's going to be relatively perpendicular to the occlusal plane? Not too bad. Looking pretty good. All right, we might be able to just come in a little bit more mesial and straighten that up just a little bit. In other words, maybe I'm drilling at about 25 degrees when I could be opening that up about 5 more degrees. So I'm going to turn this. There's where I was. I'm going to turn it a few more. And I'm going to go in just a little further. And then let's see. See where we're at. Looks like I overdid it a little bit. Maybe. No. Maybe. Maybe I went from 25 to 35 degrees. All right. But again, I'm on top of a bench top on my elbows looking at a camera that's in reverse to my eye. So I'm pretty happy with that. And let me just carry this down all the way. So my dummy implants are going to be 15. So I'm going to go ahead and carry this down a little further. See me get a little buccal penetration there. Not too bad. All right, so there we are. So that's our 30-degree abutment. All right. Not too bad. Let's look at it from above. Set the timing a little bit. Looks like it's pretty parallel. Good. All right, so we've got that one carried down. Let me go to the other side. I'm going to go to my divot. All right, I'm going to go back 30 degrees. I'm going to drop this in about 6 or so millimeters. Drop this 30-degree paralleling pin in, and let's see how we did. Maybe overdid it a little bit. We might be looking at about 35 or 40 degrees. Let me turn it around this way. Okay, but I still have plenty of time to correct my angle. So I'm going to come back. I'm a little excessive on the angle. Let me turn it up a little bit. Let me see, drop this in all the way. And let's see how we did. Drop that in. Good. Looking like we're about 30 degrees now. Very good. So if I were to look, and I only have one 30-degree paralleling pin on me at the moment, but if we were to look at our 2 in the anterior and our 2 and our 1 in the posterior, we've got a pretty nice relationship here for a standard all-on-4 right there. Okay. So now it just becomes a matter of opening up the osteotomies for the appropriate sized implant. So I believe I have 3 5x13s here. So I'm going to go to my 2-7 drill. It's a 3 5x13, and the other implants are 15 millimeters long, and I'll double check those sizes. I believe they are 4.0 over here. But I'm going to go ahead and open this up. I always drill just a little bit. I'm going a little faster because I don't have to worry about cooling the bone here. But they get that pumping motion going. I go about 2 or 3 millimeters in with the water cooling. Usually I take more breaks, let the water cool more. But we're not worried about overheating this typodont model. So move up to the 3.0 osteotomy drill. Drop that in. All right. Now, of course, in the field, if you're more comfortable, you know, especially as a beginner, you're probably only doing 1 osteotomy at a time. Maybe I'm doing 2 sometimes at a time. Sometimes I'm doing 3 or 4. It depends on the situation and the control we have in the operatory and how well everything is going and how sure we are about lining up the angles. But we can move pretty fast on these typodonts. So that's a 3-3. And as I said, I have a 3-5 dummy implant here. So we're going to move to placing the implant. All right, so let me get an implant driver out. The blue implants are aluminum. And sometimes aluminum implants don't stick as well to the drivers as standard implants, but this one's doing just fine. So we've dropped our motor down on a lower setting, and we're going to let the implant slowly eat into the model right there. Tightening up pretty good. All right, I might finish that by hand. While I've got this in my hand, I never put down an instrument until I'm done using it. That saves me a lot of time in the operatory, a lot of efficiency. If I'm ready to go with another osteotomy, I'll just load it. I got this in my hand. There's no sense of putting it down. And I'm going to go ahead and drive this one in, 23 and then 26 together, side by side. Drop that in all the way. Perfect. All right, starting to grip. That's telling me we're probably getting more than 40 or 60 Newton centimeters, but you see where we're at in the 23 and 26 position. I'm going to move right along with my hand driver at this point in time. All right, so we've got to seat these all the way down. Get this seated on the implant there. Get my hand driver out. And let's see what our torque is set to here. I'm going to set my torque to, let's just set it to the minimum torque you need to load, which is about 34 newtons. And see how the torque wrench breaks right there? Good, we've got good primary stability. Let's go ahead and turn it all the way up. I like my implants to be at 60, but a minimum of 45 newtons. So our number here looks like we're getting to about 60 right there. And we're just going to drop this in more than 60. You see the torque wrench breaking right there. Good. More than 60, that's fine. There is no danger, in my opinion, of pressure necrosis. The real danger in going over 100 newtons is fracture of your implants or components or drivers or bending and breaking of your drivers or equipment. So I will typically place my implants at 60 to 80 newtons. I wouldn't be scared to be at 100. That would be fine. But, you know, we want to try to stay above that range of 80 or 100 because we don't want parts to deform or break. So I got 23 and 26 in place. Going to take the implant driver off. You'll recall I stopped at a 3.3 because the anterior implants were 3.5. I'm going to go back to the drilling sequence to widen these posterior osteotomies a little bit. And I'm going to take this down to depth. The model actually feels very good to drill on. I like this model. It feels like a D2 bone, maybe on the verge of a D3 bone. But I mean, I take it back. I think it's a pretty good drilling bone. It's like a D2 bone. No cortical plate, no difference in texture as you go through, texture resistance, I should say, as you go through the implant model. But all the same, it's very good to drill on this too. And not a lot of dust too for a typodont model. I like that. So I switched my motor over. I'm going to grab that 15 millimeter long implant, the Epicut dummy here, dummy implant. And I'm going to let this let this drop down at that 30-degree angle. Getting really good resistance right there. I'm going to stop that one right there. Because I'm getting so much resistance on that, I'm going to switch up to my next drill, which actually in the S.I.N kit is the 4.0 implant for a 4.0, the 4.0 osteotomy drill for a 4.0 implant, which you rarely take the same size drill for a all-on-4. For an immediate load situation, we rarely take the same size drill because otherwise you just don't get the primary stability that you're looking for. So here we go. We've got our aluminum implant for placing on typodonts and the S.I.N 360 right there. And we're going to check our speed before we go to the mouth. Always a good safety precaution. And we're going to place it in there at about 30 degrees. That's a lot easier to seat in this case than the other one. Get that to dig a little deeper would be nice. Looks like I bottomed out. Might have to readjust what we're doing right there. But again, I'm working on a new model with aluminum implants. What I'll do with that situation, if an implant doesn't get primary stability, the only thing you can really do, or one of the best methods to correct that, is to take it out, drill a little deeper, then place the implant deeper, engage that apical bone, you'll get the stability you need. Then you're just going to have an implant a little deeper in the bone. You'll have to probably take some bone off or use a longer multi-unit abutment. Let's see what happens here. So you'll notice I drilled here to a 3.5 osteotomy drill, and then it was difficult to see, but we got probably an 80 torque on there. And over here, because I didn't want the difficulty, I pulled out that 4.0 osteotomy drill, and what happened? It hit and started spinning. So yeah, we got a spinner. Good, let's deal with this. We got a complication. Perfect. I like it. Let's take this out and put this on reverse. Back this out. Come on. Sometimes when you're backing an implant out, you got to put a little side pressure on there to get it to come up. Come on. Keep on backing out. Good. I'm going to take a hand driver out here. I'm going to turn this back motor off. I'm going to see if I can back this out without pushing it back in here. There we go. Good. All right. Let's put that in a cup. Let's go back. Let's drill down a little deeper and see if we can get some stability here on this implant, because I overdid that osteotomy. I'm going to put an extender on here. Pardon me if I do have an extender. There it is. Good. All right. Let's see now if we can get some stability on this implant. Where did I put my driver? Let's go to program 3. Put our implant on there. And let's let this see. Let's see if the apex wants to grab. There you go. Perfect. Love it. Dropped in very nicely. Okay, so now we got stability right there. Good. We learned how to manage a complication when you have D1 bone or you oversize your osteotomy and your implant starts to spin. Now we know how to fix it. So now it's a matter of setting timing on the implants. MUAs. Now the first two shouldn't be too tough. Got straight MUAs, right? Now you'll notice that I've got my implants in there a little deep. Now I like to keep my MUA crest a little over the bone. I don't like to choke the bone. We don't want to choke the bone with those MUAs. So when I put that in there, I don't want to see the top of the MUA right up against the bone. What's going to happen is that will take a little of this off. What will happen is that MUA will start to, the bone will start to die back if you choke the bone out. Typically, I'll put these S.I.N 360 implants a little deeper, like 1 or 2 millimeters, and use a longer abutment. Use a longer abutment so that it rises above the bone and doesn't choke the bone and the blood supply. We got to profile this bone a little bit. Not all that uncommon to place your implants and then touch up your osteotomy just a tad. All right? That's okay. I wish I had a little bit of a wider burr. It's easier to get good control. I'm finding that this is sort of digging in to the model, if you will, and we're making a good mess. That's good. Good mess. It's a sign of progress, people. Totally a sign of progress. Somewhere around here, I have another 0 degree abutment. There it is. Good. Just like so. I'm not going to turn my compressor on back here because it's going to be so loud. That'll not make for a good video. So we'll just deal with the dust. But there's two MUAs in the front. Nice, fairly parallel. I like it. Good. All right. Okay. And then we're going to use our 30 degrees. Now this is where we'll have to set timing. I really wasn't watching timing very close while I was doing this video, so we'll have to set it right now. Take a look. These are 30 degree MUAs. Okay. We can actually place the implants a little deeper so that I can get that down. I just have a few dummy MUAs here. I don't have a full inventory. This one right here looks pretty good. Number 20. That looks pretty good. I'll turn this around for you. Looking pretty good right there. All right. Number 29 appears to be a little lingual. Just a hair. Not too bad though. All right, so we're going to go ahead and drop these in just a little further. If they can go further. Why? Because I don't have a full inventory of MUAs at the moment, presently here at my disposal. So I'm using this height of an MUA. But it doesn't hurt to drop your implants in deep and then use a taller MUA. I actually think that it's if you have a platform switch, Morse taper platform switch implant, it actually is beneficial to the bone to drop them in just a tiny bit deeper. Okay. And then that MUA collar, keep it about 1 millimeter above the bone or more. Depends on the size of the tissue. In the mandible, you're oftentimes constricted because you're constricted in the mandible because the tissue is so thin. You know, you only have 1 millimeter of keratinized tissue, maybe 1.5, sometimes 2. So you're fighting a very fine line on where you can put that MUA platform in the mandible. In the maxilla, you typically have a lot more keratinized tissue and a lot more flexibility. So there you go. I dropped that in a little too far. Can't reach my implant platform anymore. Now, remember that your bone sets the tone on healing of soft tissue. So you want better looking ridges, get better looking bone. All right, that looks good. Not bad. Let's see how we do over here. Well, let me change the timing on that one, certainly just a little bit. Just turn it just a little bit. Let's see what we got. All right. So now we've got something that looks like it's going to be conducive to a nice restoration. All right. Can you see that there? Drop this in the picture just a little better. Nice. All right. Good. Not bad for a freehand looking from a real weird angle right now on a brand new model. Not bad at all. I'm going to turn this down. We got to tighten our MUAs in. Let me get the right pedal here. All right, so now we drop our MUAs in. Come on. There we go. There it is. Still not super stoked with the timing on this one implant. I know it's a model, but it's really bugging me. I just want to get this timing just put in just a little better. Gauge that implant. Good. Knocked off the straight attachment on that. All right, that's a little better. All right, so let's go ahead and tighten this one down too. Now the standard torque on the multi-unit abutment, the angled multi-unit abutment, is 20 newtons. Glancing over my shoulder, I actually see a 30 on there, so don't want to fracture that screw, but I'm just going to get it there. That's pretty tight. All right, but a 30 is the appropriate torque for the straight MUA. So we're going to go ahead and put this up here. Okay. Good. All right. So there's the mandible. Looking great. All done. Let's go ahead and, this is a real-time video, by the way. Looks like I'm at 30 minutes with talking. That's not too bad. Not for our first time. We're making quite a mess here, but it's going very well. Let's grab our maxilla now. Let's go back. Remember, the first thing we want to do in the maxilla is we want to look at our anatomical landmarks. Pencils are great. They give us a chance to outline the window of the sinuses, right? By the way, I use 3D models in all my surgeries so that I can see exactly where I want to, place implants. I'll have a model on my tray every single time. Maybe I want to look at this 7 and 10 position right here. Use my pencils, help guide me. Take a look, where is that implant? Where are we going to be aiming? Maybe up here in this M point, right up in this area. Perfect. Just take a feel where we want to be. Good. And there's the outline of where we might want to have our all-on-4, all-on-X in the maxilla. Again, take our pilot drill. Let's go ahead and put ourselves on the right program on the model. Let's just make a few dimples and then reassess. Okay, measure twice, cut once, right? Let's see. How's our symmetry? Are we looking pretty good in the posterior? All right, are we looking pretty good in the anterior? Looks like we're in pretty good shape. Now, for the maxilla, I'm typically going to be drilling at a 17-degree angle for an axial placed implant. Remember, in the maxilla, you can place implants. I'm going to go this way, so you turn this around for you. So, excuse me. If you were to place an axial implant, might be here, and you might angle 17 degrees, right? Here, 17 degrees. We've also got the option to go M point or V point. V point, M point, axial. So always 3. I'm just going to keep it simple for this and go axial placed implants. And we're going to look at our 17 degree. And drill it on this again, upside down. But I think we're going to get pretty good angles all the same. Go back to my other point here. Let's take a look. Looks like I can be right about in this area here. Good. And about 6 or so millimeters. Looks like I want to be right about here. There's my sinus wall. Pull up. Go about 6 or so millimeters with my pilot drill. Great, I'm going to put my pilot drill down. I'm going to get my 2.0 osteotomy drill out, and we're going to just go about 6 or so millimeters in each one, because then I'm going to check my angles and see if I'm at 17 and 30. Now, so looking at my front, let's see how we're looking here. Looking good in the axial direction. All right. Let's check our other one. Looking good in the axial direction here. Good. Nice. And then are we looking good in the facial direction? This looks like it could be a tiny bit too facial, right? Maybe. Definitely not going to be palatal. Let's look at the other one. Looks like, again, it could be perfect, maybe just a tiny bit too facial. Let's see how this is turning out. Not bad for drilling it upside down, I must say, though. Drop this in a little further. And let's see what we've got here on the 17 degree. All right. So I think we're going to be much better now. Now we can see that we're not sticking too far out the facial of the bone. Let's check our other one. Definitely a challenge upside down and backwards in these cameras. Okay, so let's go ahead and carry this to depth. Again, this is the axial inclination, 17 degrees in axial in the 7 and 10 position. We had the option of also going M point or V point. Now I've got that to depth. I'm going to come back here to my posterior area. Take a look at this in the occlusal view of the model, right? And I'm going to drop this in a little bit, and we're going to see. Oh, looks like I'm in the sinus just a little bit. No problem. Let's just move forward. There we go. All right. And let's see where this is coming out. Are we looking good for a 30-degree inclination? My screen is very small, I'm looking at, but I think we've got a pretty nice angle for a 30. Let's see. Yep, looking pretty good. All right. Drop that 13. Drop that into 15. All right. You'll notice that on that first one, I kind of zipped my sinus a little bit. We're working here kind of quick, pretty hasty, I'll admit. But not like if that didn't happen in an operatory, you couldn't just reposition your incorrect right away if you recognize what you've done. So here we are in the 30-degree MUA. Looking up from the occlusal view, looks pretty good. All right. Drop this in. Now, got this all the way to depth for 15. Good. And you don't have the benefit of the patient doing this with the patient, but you can go ahead and take a look and look in your axial view, and you can see I'm not in the sinuses right there. That looks great. So take my 2.0 away, and I'm going to go up to the 2.7 drill. Got the 2.7 here at this point, and we're going to carry these down to the 15 for that 13 millimeter implant. And we're going to carry this down to 17 for my 15 millimeter implant. Now, I will say for this exercise, I'll be using the standard drilling protocol. Very common for me in the maxilla on the, in the natural patient. It's very common to use just the 2.0 osteotomy drill and then use some densification. Now, back in the old days, densification used to mean osteotomes. These days, we're using versadensiburs on almost everybody in D3 and D4 bone. So it might be just a pilot drill and then versa drills. So, and we always undersize our osteotomies. Now I'm expecting this maxilla to feel similar to that mandible. I don't expect a big difference like you sometimes see in patients between a mandible and a maxilla. I'm just using all my osteotomies at the same time. There's my 3.3. I'm going to go up to my 3.6 for my posteriors because, again, these are 4.0 implants and my anteriors are 3.5. And I had a little trouble seating them at the 3.8 in the mandible, but at the 4.0, it went in way too easy. So I'm going to do the 3.8 and we'll see what happens. Stop that. Good. Now, all my osteotomies ought to be done. Put our driver on for our implant placement, change our motor speed. We're going to pull out a 3.5 by 13 S.I.N 360 EpiCut training implant, and let's place it in the number 10 position. Don't you wish you could move, manipulate everybody's head just like this? Usually when that starts to tighten up, I'll ask for my next implant, get it handed to me while I start hand ratcheting that first one in, and I'll be usually I'm placing 2 at a time because I like to feel the bone. I like to kind of expand the bone. I'll be going in and out. It's called self-tapping, right? So those are pretty tight right there. So we could do this. We put one in, let it expand the bone, then go to the other one, let it expand the bone. You might have to come over here and pull this one out a little bit, let it relax the bone, go back and forth, yada, 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 as they say. Drop these all the way in. Usually, again, Morse taper implant with a platform switch, usually about 1 millimeter below the crest. Depends on the thickness of the bone, thickness of the tissue, quality of the bone, etc. But those look like they're ready to be timed. Let's pull out the 15 millimeter implants. These are 4.0 by 15. Get that to engage right there. Perfect. And let's drop this into the position in the premolars. Standard position, a lot of times in the maxilla, it's the first bicuspid. Good. More than 60 there. I'll usually tell ask my assistant to please send me the other implant, and we'll get that started. That way we can self-tap and seat both implants at the same time, save a little bit of time. All right, drop this in. All depends on how preoperative the patient is. Of course, my patients are all under general anesthesia with double throat packs. So we are able to move a little bit more efficiently, a little bit more quality. Got this in. Great, 60 plus right there. Feels awesome. Do the other one. 30, looking 45, into 60, 60 plus. Okay, 80. That's a great. Okay, so now it's a matter of setting the timing. Here I have my 17 MUA for the front. Now this is a tricky area cosmetically. You make sure that you got that transition line up high enough, but you want to get that MUA down low to the bone just in case you don't have any cosmetic issues. All right, well there's my, I didn't even check the timing, but we're not looking too bad. Let me turn this around for you. Looking good from that perspective. Good. Let's look from the front. Got something we can definitely correct. By the way, if we're using a screw like a vortex screw and you're worried about this being a little bit too facial, you can always pull them back 17 to 25 degrees, and depending on the material of restoration, and we'll be able to have that access hole hidden. Let's go ahead and put on our driver for our MUA screw, channel screw. I'm not going to mess with those angles. They look pretty good. Not bad first try. First time. I saw this on YouTube once. Always laugh because somebody's always saying, I don't need to come to class because I saw YouTube University. Yeah, not my doctor. Not my doctor. I mean, we're not learning how to water ski here, people. We're this is a little bit more technique sensitive, right? Yeah, when I learned how to wakeboard, I pulled out YouTube University. When I want to learn how to cook something, that I can throw away and we can all order pizza, I might pull out YouTube University, but not on people. Not on people. Story, I had a guy tell me he didn't need to come to class because he had YouTube University. He learned everything on YouTube and he did all-on-4 and he was just fine. Had a attorney contact me to see if I could defend a dentist. Needless to say, I recognize the name. All right, let's check the timing on these. So this is not good timing. All right, yes, we sometimes want them to be a little lateral because the maxilla is often compromised in width compared to the mandible, but we don't want them to be that wide. Let's see if we just change the, now we're looking too palatal on that number 12. And actually, the number 5 doesn't look too bad. That looks good, I think. I like number 5. I think number 12 needs to move a little bit. Let's go ahead and sink number 5 in. 5 will be good, especially if I was doing an analog conversion. 5 might be a little more ideal. A lot of intricacies of all-on-4 between analog and digital. Digital, I could afford for this to be pushed a little more laterally. Ideally, I wanted a little more lateral. We've got really small screw access holes. We don't want to pick up a denture. But if I was doing an analog conversion, excuse me, having this just a little bit more straight up and down allows me to pick up the denture without grinding out the sidewall. Excuse me, I'm getting over a bronchitis. But it allows me to pick up the denture without grinding out the buccal flange of that or having any difficulty. Whoa, that is way too buccal right there. Let me turn the MUA and see. Well, that's pretty nice. All right. Looks like something we can live with. Like it. Let's drop it in there. Next step, conversion. Excuse me again. We're pulling to the end of this. We're just about done. We're going to take a break and clean up before we post a conversion video. Looks great. All right. Not bad for a freehand surgery while looking backwards into 3 monitors for the first time on this model. Pretty good. I'm happy with it. Bring this together. It's like something we can live with. Turn it this way for you. Looking good. Nice. And that's the way your models should look right before we get ready to convert them. Perfect. Okay. Now we get our armamentarium out with the, we got everything out. We'll do our analog denture conversions, or you could do a digital conversion either way. All right. Thanks for watching. I hope we all learned something here. Oh, you know what I'm going to do? When we turn this off, I'm going to correct this one a little. I'm going to turn this one. Looking from this angle, I just realized that it's hanging out a little bit palatally. I don't like that. Yeah, we're going to turn this one out. Just, you know what? Let's go ahead and do it. Go ahead and do it. Let me show you. Perfect. So we're going to back this out. Going to take a minute. But hey, complications happen. You know what? I can place my implants sometimes, oftentimes. I can place the implants faster than I can place the MUAs. And I don't mean incisions and extraction. You know, you do your incisions, your extractions, your alveoloplasty. Then from that point on, start the clock. I can generally place the implants faster than I can select the MUAs. And why? Well, placing of the implants is easy. The hard work is everything you do in preparation of that or after that. Get this right. I'm going to turn this off. The MUAs, though, wherever you place them, you either have to live with them. The patient has to live with them for life. That's a big number, life, a big long number. Or you're going to be spending chair time trying to change MUAs, explain to patients why you have to change what you did, what you're doing. You know, maybe numb people up, trade out MUAs, take all new analog pickups, or take all new digital scans, deliver new teeth. You're basically getting frustrated. You're losing time and money and losing patient confidence when you have to change MUAs. So take your time selecting your MUAs. If you see something that's wrong with an MUA, correct it right away. Don't wait on that. Don't wait on that. Correct that right away. That looks a lot better. So let's go ahead and put that down. Good. Glad we noticed before we did an analog conversion. Makes life a lot easier. Fix always, whenever you're in building, you see a problem, fix it early. You're building something, you're building a house, you're remodeling a room, you're doing an all-on-4. You see a problem, do it now. Fix it now. It's just going to lead to greater problems if you don't, right? Okay, now, yeah, I'm generally a lot happier with that. I don't think it's so far palatal anymore. Looking great. Okay. Well, thanks for watching. 47 minutes, not bad. Full all-on-4 surgery, brand new models over the shoulder from 3 different angles. I like it. Looking good. Atlantic Implant Institute. Follow us TikTok, YouTube, LinkedIn, Instagram, Facebook. DM us for details. We've got classes on stackable guides. We've got classes on freehand surgery. We've got classes on Module 1, Basics, Fundamentals of Full Arch, Boot Camp. Module 2 is Advanced Prosthetics and Digital Workflow. And Module 3 is Remote Anchorage. We also have a core continuum. You can take all 3 modules for a discount price. Forgot to mention also the cadaver labs, Basic Cadaver Lab with Fundamentals, and Advanced Cadaver Lab with Remote Anchorage. And one more thing, don't forget ORCA, live surgery training in Guatemala. Level 2 is your standard all-on-4. Level 3 is remote anchorage surgery. And don't forget level 1, the most important one, prosthetics. Practices live or die in prosthetics. Mark my words. Everybody wants to know how to place implants and do sexy all-on-4 surgery. Your practice will suffer if you don't know prosthetics. That's why it's Module 1 in Guatemala. Don't overlook the pros training. So you can come here to Virginia Beach, Virginia, and we can go through it here and then follow up in Guatemala or do one-on-one training at Full Implant Choice. All right, everybody have a great day. I'm going to go enjoy the rest of my Saturday, and I'll see you soon here in Virginia Beach.